I'm really excited to introduce Dr. Christie Bartels to you all. I've known her since I came to UW, essentially, and she's another investigator in the Health Innovations Program. And her research focuses on bridging specialty and primary care, and she's studied some very cool interventions that harness the power of the electronic medical record to improve treatment of hypertension and smoking cessation, as well as increasing physical activity. And I thought that her sharing her work with us would be particularly relevant because of our departmental priorities right now focused on improving care of obese patients, which is something that we don't really feel very comfortable doing, and we're sort of struggling with how to get folks how to initiate referrals back to primary care to address those issues. And so I thought that lots of what Dr. Bartels has done would be relevant to us. She attended college and medical school at Creighton University in Omaha, Nebraska, and then she came here for residency in internal medicine and completed her fellowship in rheumatology here as well. She's been on faculty on the tenure track since 2013 and was a professor here before that on the CHS track. In her short research career so far, she has over 45 peer-reviewed publications, and she has grant funding from NIH, the Wisconsin Partnership Program, and multiple foundations. So she's extremely accomplished. And so I'm really thrilled that she's here to share her work with you. So join me in giving Dr. Christie Bartels a warm welcome.
So as Heidi mentioned, I'm a health services researcher and an implementation researcher. And one of the things in those two hats is that I have tried to help make it a bit easier to do the right thing for patients in bridging specialty and primary care. And that's kind of been my line. So I hope that that'll resonate with you, even though I'm a rheumatologist. I think we share some of the same challenges, and I hope to kind of bring us into that today. My quick disclosure is some of the science that I've done here, actually one of them was funded by an independent Grants for Learning and Change with Pfizer. But as Heidi mentioned, I have a number of other funders as well, and that was a peer-reviewed independent funding source. I will not discuss any unlabeled use of medications as we proceed today. The first question I'm going to toss out there is actually just to get everybody engaged here. I'm going to ask you that of the 2.9 million visits across the UW Health enterprise that happened in 2015, how many do you think occurred outside the classical defined departments of general medicine, pediatrics, and family medicine, knowing that you all provide some primary care as well, but just thinking how many of those 2.9 million visits do you think fell outside of this department, those three departments? Do you think it's 900,000, 1.4 million, 1.9 million, or 2.2 million? So I'm going to just get a show of hands, if you don't mind here. So how many people think it's just about 900,000? Anybody? Yeah. 1.4 million, about half. Okay. Lots of hands there. 1.9 million, a lot of hands there. And what about 2.2 million? So the answer here is 2.2 million. So most of the visits to UW Health actually occur outside of those kind of classically defined primary care fields. And you guys are right in the thick of this, right? So you bridge that for young reproductive age women and women throughout the life cycle. And again, I know some of you are advanced subspecialists, and so I'm hoping that this will resonate with you. But basically, UW Health recognized this, that right, we need to really think about this whole medical neighborhood across the life cycle. For some people, doing classical primary care, and then some people also doing things that again border primary care. We need to think a little bit about how we can connect, thinking about holistic health and things that matter for longevity for our patients. And so this is how some of this work began and got some traction here at UW Health over the last few years. And now we're doing these interventions as well at other centers. So my objectives for you, and that first slide, were basically just to think a little bit about this magnitude of this population health issue. We have a ton of visits that are happening all the time, and in some of these visits, we're sort of missing the opportunity to intervene, even though we're collecting data, like blood pressures or weight, as Heidi mentioned. The other thing we'll talk about is this term called medical neighborhood. So we'll go into some better detail there. We'll talk about how to set priorities, right? We can't do everything in the context of these visits. We're doing a lot of other things. There's a lot of primary focus. So how do we set priorities? And then we'll illustrate some interventions that, again, we can get our clinic staff engaged to do the right thing for patients and not make it too painful on our day-to-day practice life. And we'll show you some evidence-based practices from the literature, but we'll also illustrate specifically some of the interventions we've done to look at hyper blood pressure, smoking, physical activity that we call the BP Connect, Quick Connect, and Fit Connect interventions. And my goal for you by the end of the talk might be to identify about one opportunity that might actually be applicable in your practice. So think about this as we're going through. Is there one thing that you might be able to tackle in your practice? And at UW Health, this is something that there is some interest in looking at expanding some of these interventions across other departments. So I would love to have a bit of a discussion to think of how this might resonate here and elsewhere. So, the first piece that sometimes people ask me is, you're a rheumatologist, why are you into like cardiovascular and preventive care, right? So the answer to that is that the fact that patients I take care of who have rheumatoid arthritis or lupus die about 5 years before peers. And it's usually not from rheumatoid arthritis or lupus, it's actually from cardiovascular disease. So it's hugely humbling to me when I get a 25-year-old woman with lupus and she says, is this going to affect my lifespan? And I'm like, yeah, you're going to die about 5 to 10 years before peers, right? I don't say that, obviously. But it's one of those things where you say, boy, that's a big deal. So one of the things that my research, the first 5 years or so of my research, was mostly descriptive work. And in that descriptive work, I was looking to say, do they get the same preventive care as everyone else, patients with these conditions? And it turned out that they didn't. They had more context to the health system, but they got less preventive care. But that actually happened even if they had at least one touch with primary care, defined as family medicine, internal medicine, OB-GYN, pediatrics, or geriatrics, that if they had any of those people involved in their care, they still had care gaps because of this sort of dispersion of care. And I think you can picture this. I don't think that's hugely surprising. I'm getting a few nods from the front here. So we found out that basically they got less CVD prevention than peers. Part of that story was that 75% of their visits were in specialty clinics, right? But the other piece of this, and that's not unique to rheumatology patients. In the US, actually in 2013, specialty visits outnumbered primary care, right? So if we're missing the boat on those opportunities, we're kind of missing a big chunk here. And there are a lot of special populations that have unmet preventive and population health needs. And to bring one specific to your literature, a colleague of mine, Wendy Bennett at Hopkins, who is in internal medicine and works she actually is the director of the Women's Health Center there. So she's in internal medicine. She works with folks in obstetric gynecology, lots of other departments. And her interest is really obesity and pregnancy and follow-up care for medical issues in the postpartum patient. And she did this great study saying, we know that complicated pregnancies, things that have patients who have gestational diabetes or have preeclampsia, eclampsia, hypertension during pregnancy, we know that over the life course, they're at increased risk for diabetes and for having heart disease. So she asked the question of just within that first 12 months, that guideline recommendations, for instance, for follow-up of hypertension, say within 12 months, you should see primary care and talk about that hypertension follow-up. Even if it was mostly a pregnancy issue, you should get connected to care. So she asked the question, how many of these patients are actually connecting back to primary care and or obstetric care within the first 12 months after a complicated versus uncomplicated delivery? And what she found that it was among Medicaid patients, just over half actually connected within 12 months with their primary care doctor. And within that 3-month period where folks would be seeing them in the OB clinics, again, only 60% of people also connected with their 3-month follow-up appointment in the Medicaid patient. And when they looked at the insured population, they did just barely better. So again, nearly half of the patients after a complicated pregnancy are not getting connected back to care where they might get some long-term care for things like blood pressure or chronic health issues. So again, this just kind of highlights, I think, this issue of bridging and how we can be more mindful. And this is just one example of many. So the term medical neighborhood that I got really excited about is basically saying, we spent a ton of time, I think, in the last decade thinking about this patient-centered medical home. But as you all know, not every patient just fits neatly within one single home, right? Often they are seeing other providers or their life is complicated. And with you all, you probably are connecting them to community resources, things like the WIC program, other things like this as well. So we need to think a little bit more broadly when we think about health delivery. And this medical home and medical neighborhood brings that definition to play. So they say it's the patient-centered medical home and the whole constellation of other clinicians and the community and service organizations. And I think, people hear that and they're like, yeah, I could buy that, right? That sounds like a good idea to think about coordinating across those settings. And yet executing that can be really challenging. So when we think about executing that, one of the things we did as a research team was just saying, how do we prioritize? How do we pick a couple of things that we think will be particularly high yield in the life courses of patients, right? So the couple of things, one of the studies that I loved was a study actually done by the CDC that was published in the American Journal of Preventive Medicine. And in this study, they actually looked at if we could increase the percentage of people using specific services, how many premature deaths could we prevent? Okay, so what's the bang for the buck for preventive services? And I love this slide. So basically the kicker here is basically you're looking for slope. The power here is slope. So the first slope that kind of grabs your eye is hypertension treatment, right? So you look at hypertension treatment and you see, boy, if we could get average care in the US to get from 50%, which is what the CDC says it is nationally, even just up to say 55, or actually, let's say 60%, we actually can get them about 20,000 lives saved, which is pretty amazing if you think about it. That's a lot of lives with just a simple intervention there. And then likewise, interestingly here, smoking cessation. If we can get, rather than just 5% of people in the US who smoke using cessation services, they don't even have to quit. They just have to be trying to quit or using services, that we can save another 10,000 lives. And when you contrast that with things we do every day in our clinics like vaccination, what you see is that smoking gain is actually over 3 times what you would get by almost acing the test for pneumococcal vaccination. So I would say, maybe we should put some more effort on things that are high yield, that are going to impact life course for patients. And so this is what we've done. So we started with hypertension, and we designed an intervention that we called BP Connect. So with BP Connect, here's some just basic kind of evidence basis in high blood pressure care. We just started off by just educating MAs, nurses, physicians, on why this matters, that sometimes rheumatologists didn't think this was in their domain, but we'd say, hey, this matters, and we can help your clinic system fix this for you. And here's why it matters. The first is that 1/3 of adults have hypertension, and only half of them are controlled. And that's probably not surprising to you. They probably walk into your clinic, and you have 1 or 2 every day that have a high blood pressure. But the other piece that I think people aren't aware of is that you only have to treat 11 patients to prevent 1 MI, stroke, or event. So a number needed to treat of 11 is pretty phenomenal. So this is huge yield for just modest care. The other thing is that now Medicare has quality reporting measures. And again, we're an ACO at UW Health, and so we may not use these particular measures, but there are measures now endorsed by 24 specialty societies, including the obstetric gynecologist, saying screening and timely follow-up of high blood pressure. We may not own control of blood pressure, but we're going to own that we're going to get you to timely follow-up is a quality measure that we're going to report nationally. And that timely follow-up they define as 4 weeks, saying getting people back to care within 4 weeks to get a measurement. And again, CDC has really come out broadly to say that nothing would save more lives than using protocols to just make sure that that happens, that patients get timely care and get follow-up. And here's a little bit of the evidence for that. So there was a lovely study done out of the Kaiser group. Again, this is mostly in primary care clinics, but Kaiser actually started out exactly at that national average with about 50% of their patients having controlled hypertension. And what they did is they gave simple protocols to medical assistants and nurses to say, if patients are high, remeasure. If they're still high, here's an algorithm on how to go ahead and treat them. And what they found over time was they were able to get control up in their group up to 80% as compared to peers in California and nationally. So this protocol care actually improved care and improved hypertension control. And again, it was mostly a staff-directed intervention. So we asked the question, could you do that in a setting that maybe doesn't consider hypertension as a central domain of their care, right? So could I do this in rheumatology clinics was one of the questions. So we said, what's happening right now in a rheumatology clinic? And what we did is we did a couple of studies that we published where we said, when patients come in with high blood pressures, what happens then? And what we found actually was that we only overtly recommended follow-up in 1 in 10 of those encounters. And didn't matter how high the blood pressure was. We actually tested that too. We thought maybe, when it's super high, we'll address it. And it turned out that the numbers were about the same. We mentioned it in about 1/3 of visits. We only recommended follow-up in 1 in 10 visits. And when we asked patients, what does that mean to you when we say follow-up in primary care, they had no idea, A, maybe what the boundaries were, why it wasn't being addressed in rheumatology, and B, what follow-up meant. They said, maybe like the next year or 2, if I get in, it's probably good, right? They don't know what that means. So what we found is the other piece that the patients told us that they assume, if nothing is said after a blood pressure is mentioned in a clinic, they assume it's normal. So it may be the fact that we're actually doing harm by measuring a pressure and not giving that patient feedback at that clinic visit versus not measuring at all. So this was really a wake-up call for us. And we said, boy, we can do better than that, right? So we sort of envisioned what would be kind of an ideal state? What would be better than what's happening right now? And we kind of envisioned the protocol, again, saying, let's remeasure the pressure, be sure that we actually have a hypertensive patient, not that they just rushed into the clinic, right? So if we could remeasure that and cue that, and then what if they did measure high, we could just alert that EMR to basically ask the MA or nurse to say, hey, could we offer you primary care follow-up, and just blow that order out to the scheduler to just make that happen? What if we could just automate this? And so that's what we set out to do. So we did a quasi-experimental pre-post study in 3 rheumatology clinics. We set it up for a 6-month trial period, and then we watched it over a total of 24 months. All the adult rheumatology visits who had elevated blood pressures greater than 140/90, greater than or equal to 140/90 were included in the study. Basically what we did with the staff was we set them up with a protocol that we said, check, advise, and connect, right? So first, check. We want to go ahead and measure the pressure, remeasure if it's high, and then we actually, with feedback from the MAs and nurses, even nested talking points in here for this advise piece. So this is sort of interesting. They told us they just need a little script. They need to know what to say and how to make it sort of pithy and fast. We nested talking points right into those automated EHR alerts for them, that they could really make this easy and automate this. So they could say, we're concerned because it increases risk for heart disease and stroke, and we could help you schedule follow-up. Would that be okay with you? And if the patient says yes, they can tick a box on a smart set and blow it out to the scheduler, and that's the connect piece. The other piece that we did here was we did monthly audit feedback with those individual MAs and nurses to say, how are you doing? Are you getting your rechecks? Are you making the offer for follow-up? We realize not all patients will follow up, but are you at least offering? And then showing them the difference that was making. And so we did that at 4 time points. And again, that was about a 5-minute interaction with staff where they could see their individual data that happened 4 times over that 6 months. We said that we would engage the staff. Again, we asked them for feedback when we designed the intervention. We educated them on why it matters. The reminders were built in the EHR, and then that feedback was, again, a core component of that implementation. And our research question was really, could this protocol in a specialty clinic improve timely follow-up? Could we get people back in 4 weeks? And this is some work that we're working to publish right now that actually was done. I'm going to give a quick shout out to Katie. That Katie's husband has helped us with the statistics for this project, so this is fantastic as well. But what we found, which was tremendous, that basically when we looked at the 6-month data, we saw that we doubled the rates of timely follow-up, and on average, the intervention took 4 minutes at point of care by my MAs and my nursing staff. So we thought this in itself was a pretty impressive finding. That was robust to adjustment for all different patient factors. The other thing is that we dropped that time to next follow-up. The median time to next follow-up dropped from 71 days to 38 days. Again, pretty significant finding here. And then this again was work that Emmanuel helped us analyze, that when we looked over trends over 2 years, what we found is we had a population level decrease in blood pressure. So this was an unexpected finding. We didn't think we'd be powered for this, but take a look at this, that when we looked at baseline blood pressure, high blood rates of just people walking through the door with a high blood pressure at baseline, it was around 17%. And after the intervention, we were averaging around 8% of visits. So we had a 9% decline in the number of people walking through our doors. So the other cool thing that I could tell the MAs and nurses is that if you do this at the beginning, you're going to decrease the work you're going to have later on, because people are going to get under control and they're not going to be repeat offenders who just keep coming in time after time after time. And it's great for patients, right? It's going to decrease their risk for stroke. So this was a success story that we could feed back to our staff. Even even our clinicians who said, it's going to take an extra 4 minutes for maybe an average of 1 to 2 patients a day, right? It happens in about 1 in 10 patients, about half of those normalize. Even our physicians who said, clip, 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 don't slow my clinic down, and we're kind of curmudgeon-y at the beginning, by the end, we're totally on board with this because they didn't have to do anything and the right thing happened for the patient. And for other folks, they were engaged and they said, obviously this matters and I'm willing to help, and they were excited about it too. So again, physicians liked it. The MAs and nurses actually also gave us good feedback. So this is just some data that we got from the MAs and nurses, where we asked them at baseline, how confident are you in your ability to do something about high blood pressures in our clinics? And what we found at baseline was about 20% of them said that they were somewhat confident that they could do something about high blood pressure in the clinics. They were either very or extremely confident. And after the intervention, 90% of them said they felt pretty confident they could do something about it in our clinics. And we got great quotes for them. Basically, at baseline, they said, there is no system. I have no idea what happens. And a lot of times they were feeling kind of vulnerable with that, to be honest with you, right? So they were saying, I measure high pressure, I tell the doc. Sometimes the doc responds, and sometimes they don't, right? And so the MAs were feeling kind of vulnerable there. And now they're saying, you have so many high ones. It's always like, it's always like that. But when you get used to doing the protocol, it's actually easier. And again, that's what we set out to do. So this was a good testimonial for that piece. Any questions on this intervention before we go to the next here? All right, and we'll have some time for questions at the end as well. But we're pleased with that. We're actually implementing this right now with the Gunderson Health System, and we'll be continuing to study that as well. So the next piece that we did, again, with these same 3 clinics was thinking about tobacco cessation. Thinking, again, in my context, that tobacco use actually increases autoimmune disease, which is sort of interesting. Also increases cardiovascular disease, which I already told you my population is predisposed to. And if we think about that in your context, obviously you're having these conversations with folks during pregnancy, you're having this conversation with patients who've had gynecologic malignancies and people over their whole life course, right? So this matters, right? So what's the evidence behind tobacco cessation? And again, I brought this evidence to our clinicians and our MAs and staff. And one of the things that surprised me that I didn't know was that 70% of smokers consider quitting every year and 40% try. So I had no idea, right? I think sometimes we get a little bit of therapeutic nihilism. We think, I'm never going to change that, so I'm not sure how much effort I'm going to put here. But it turns out that people are trying. So if we can give them a little leg up and boost here, you can actually make a big difference. So it turns out that the other cool thing is that there have been 2 Cochrane reviews that have been separate, one with MD advice, one with nurse advice, or actually they even included in here dental hygienists could give the advice. And the odds ratio for the impact of these things, while they were not compared head to head, but the odds ratio is remarkably similar. So it can be the staff, it can be the doc. And again, if we can just get the system to help us with this, we can make a difference in care. So this is sort of an interesting finding. The other piece is free tobacco quit lines, like the quit line here in Wisconsin, can help people's 6-month abstinence improve by 60%. So if they don't cold turkey it alone, but they have a little bit of support, maybe with a quit coach who helps them set a quit date, make a plan for what they're going to do with craving and things like this, they're 60% more likely to be abstinent at month 6. And again, there are quality measures nationally that have been endorsed by 20 specialty societies, including yours. This matters. And basically that we were asking at all the visits, do people smoke? But we were not doing a great job about following up on that. And here is some of the evidence we use to kind of, again, adapt our approach. So this was kind of a cool study that was done comparing what was usual care and primary care practices, where we would just kind of maybe at best case scenario, we'd hand you the card and say, call the quit line and try to see if you can get some help, right? We'd give them a brochure at the clinic. They showed this passive, they compared the passive referral model to a model where instead we said, would you be okay if we had the quit line call you to talk to you about this? And when they did that active referral where they sent it out and had quit line call the patient, patients were actually 13 times more likely to engage in that care. And that's pretty amazing, right? So if we can kind of connect that, we can make a huge difference here. And so we said, again, what's happening right now in our clinics and how could we sort of model this in a place where maybe we don't think smoking cessation is our central reason for being? So we said at baseline, what we analyzed it, and what we found was, again, it was very similar to the other data that we analyzed, that in visits with smokers, we addressed it and discussed cessation 1 in 10 encounters. So we were failing most of the eligible encounters. We actually recommended referral to quit line in 1 in 175 encounters, which is abysmal for a free resource, right? It turns out that quit line in the state of Wisconsin also will give people 2 weeks of free nicotine replacement therapy. So, I mean, they have some tangible benefit resources, and we were sort of missing the boat here. And what turns out is that when we interviewed patients, they were completely unaware that their rheumatic disease might be worse if they continue to smoke, or that their meds might not work as well if they continue to smoke. And they said totally that would matter to them, and they wish someone had told them, a decade before, right? So patients cared, they were unaware, and we said we can do better than that. So what if we could just cue the question to say, we think some of you are already ready. What if we could just ask among people who say, yes, I'm a smoker, just ask, have you thought about cutting back or quitting in the next 30 days? Make it a pretty non-confrontational question. And it turns out when you ask that question, about 1/3 of people say yes, which is crazy. These are easy asks. And then among people who say yes to that, what if we offered to have the quit line call them, and then we could electronically send it and then see what happens on the other side of that? And so that's what we did. And again, that would help patients realize the rationale and the resources to quit. So we did the same thing, a quasi-experimental study over 6 months, where all visits to our 3 clinics with active smokers were eligible for this. We used a very similar model. Again, we called it Ask, Advise, Connect. Just ask them about 30-day readiness to quit. We trained the staff on why it would matter. The EHR would actually cue asking those questions if they hadn't asked about 30-day readiness to quit, for instance, so we could sort of train that in our staff. At baseline, they were using that button that already existed in Epic 3% of the time. So we needed to kind of reinforce use of that. And then we could connect them by sending this electronic referral that would then have the quit line call the patient. And then again, we use this monthly audit feedback model, the same exact implementation components. And we asked this research question of whether we could actually improve quit line referral and cessation compared to usual care. So first of all, that readiness to quit or cut back in 30 days. So I don't know, this was not a question I used in my everyday life, but this turned out to be a wonderful question. So when the MAs and nurses asked our patients this, again, 30% of our patients said yes, they'd thought about cutting back or quitting in the next 30 days. So this is a really easy win for people who already are motivated to make a behavior change, which is pretty cool. And then when we looked at how well we did across this, our tobacco assessment improved some. UW Health actually asked the MAs and nurses and has given them feedback for about a decade on this. So they were already doing pretty well, but we improved that by about 40%. This readiness to quit and the adjusted odds ratio, we increased this 120-fold, which is amazing, right? No one was using the button at baseline, even though it existed in the EMR. And then it turned out that our quit line referral rate increased by 26-fold. So this was huge. And on average, the intervention took 90 seconds. So this was an easy win in our clinics and was well received by patients as well. This resulted in 107 quit line referrals over the last year from just from 3 rheumatology clinics. And at Gunderson Health System, where we did it for about 4 months, they were up to 20 referrals from just a single small rheumatology clinic. So that was pretty impressive. And again, pretty easy. When we went back and asked the MAs and nurses, how did it go? Were there any issues? They said, actually, it makes it pretty easy and it worked. And we asked them, about that self-efficacy question. We said, at baseline, how many of you are very or extremely confident in your ability to provide care? And you'll see here on this one, only 10% were very confident they could do something about smoking cessation, and nobody was extremely confident at baseline. And after the intervention, 90% of them again said, I feel really confident I can do something about this, which is pretty cool for a brief intervention. And the other really cool thing that we found with our MAs and nurses that I think actually also would probably resonate with all of you who are trying to get care teams motivated to deliver care for patients is that we asked this really interesting question about clinic readiness to change. And we said before the first pilot, we asked this question. We said, my clinic enjoys trying new things to help patients. And none of them strongly agreed, right? They had not ever been engaged in sort of quality improvement. They were like, not really. After the second intervention, we asked the same question, and the response was up to 40% agreeing strongly that their clinic liked to try new things. So we basically built capacity and engagement of our staff, which is a pretty cool thing too, that should help resonate with other interventions down the road. And again, this was kind of a cool byproduct of the intervention. Any questions about that? So the home stretch here is looking at physical activity. So this was not on that chart, but it's just something that we all kind of get is a good idea to improve physical activity. Obesity, obviously, we deal with, again, every day. We're getting high BMIs in our clinic. And then sometimes we say, what do you do with that, right? How do you logically deal with this? And for this intervention, my evidence-based slide here is that basically that I share with folks is that there was an interesting study in the Journal of the American Medical Association, where they looked at comparing really sophisticated models, where they took your age, your gender, all your comorbidities, where you live, your socioeconomic status. They threw the kitchen sink at the modeling to say, how long will you live? And then they did a model where all they did was say, how fast do you walk? And how fast do you walk actually trumped everything else to predict how long you're going to live. Which is kind of amazing, right? So no one has prospectively proven this, and yet that's kind of compelling, right? So I tell people, we could get you walking, and I tell people this, they walk in my clinic, they say, I have arthritis, I'm not really sure if I want to exercise, and I say, what, the greatest predictor of how long you're going to live is how fast you can walk. And that kind of motivates people, to be very honest with you, right? So this is kind of an interesting study. So we wanted to say, what's the evidence base out there, particularly what we know is that walking pace predicts survival. That's one. Two is that in patients I take care of with arthritis, it turns out that walking reduces pain and fatigue. And how many people in here have had someone in the last month who's complained, I'm tired? Is it my thyroid or whatever, right? I'm tired. I don't know if you don't have to raise your hand, but probably a few people in here have heard this from patients, right? So it turns out it can improve fatigue as well. And these might be some footholds where we could have these conversations with patients, rather than stigmatizing things like obesity, we can say, hey, you're tired. You know what would really help that? We could get you walking, right? So we can kind of get some leverage. And the other piece is that, again, this doctor recommendation matters on this one, that patients, doctor recommendation matters to increase people's physical activity level, that if they're being held accountable, it definitely improves. And I know Heidi mentioned that you all are targeting obesity in patients as well. And actually, patients rate physicians who comment on their obesity better than patients who don't. That Wendy Bennett, again, at Hopkins has published that, which is kind of amazing. So I think we all get a little bit squeamish, but it turns out patients are okay with some of these conversations, and particularly if you just say, let's get you active. We're not going to just talk about your weight. Let's just say, let's get you active. So CDC endorses 5 different programs that are specifically tailored to patients with arthritis, and we just picked one of them called Walk with Ease. And the cool thing, I guess, about Walk with Ease, I'll tell you really briefly if you have ever seen anybody with arthritis, but again, it could be even people with spinal stenosis or degeneration, like a little bit of knee-OA. Turns out this is all free online. It's tailored to 3 activity levels, and they can do it through an Arthritis Foundation website. They can actually log their own. So there's a self-directed component. And then what we did is we partnered with the YMCA at Gunderson in La Crosse. And so YMCA was our partner, where we had them get a trainer trained with an online training that was freely available to lead this program. And we had 20 patients go through the program, and we improved pain 2 points on a visual analog scale. And just FYI, ibuprofen improves pain about 1.4. So walking was better than ibuprofen for knee pain and arthritis pain. We improved fatigue 1.7 points on a 10-point scale. And again, most of us have almost no tricks up our sleeve to improve fatigue. And 100% of those patients said that they were thinking that they would still walk at 3 times a week, which again, if we compare this, it was actually also cost effective, that we could get 18 sessions for the price of about 1 PT visit, which is kind of phenomenal. And if you think about people who finish PT, how many of them do you think would say, yep, I'm committed, I'm gonna walk 3 times a week after PT versus after a program like this? So it's kind of cool that you've also now reinforced a lifelong behavior change, perhaps. And so again, we found that this was a nice way to connect patients. And the connection with this also is that we recently got clearance through Gunderson Health System to actually build this into their EMR so they can electronically refer through an interface to the YMCA. And I don't have data on that yet, but we're excited, again, thinking about this as a medical intervention, that at your clinic, you could just say, hey, I can refer you to this free program with the YMCA. Would you be interested? And you could just click it, blow the order over, and that's how you can get patients to engage. That then YMCA will reach out to them, enroll them in the program, or talk to them about enrolling in the program. So hopefully I have kind of laid out some pathways for you to think about what are these priority prevention opportunities across really diverse settings. And again, I know all of you kind of practice in diverse settings. So what are those opportunities and priorities? How staff protocols can really make this happen without making your life a lot more difficult, and improve outcomes. So we saw in our BP Connect that we doubled timely follow-up, which is what we set out to do, but we 9% improved rates of high blood pressure. I mean, that's pretty impressive, I think, and we didn't set out for that endpoint, or didn't think we were powered for that endpoint. So Quit Connect, we 26-fold increased our quit line referrals. We actually have some new data saying that among the people who accepted that referral and took that call from quit line, 24% of them set a quit date or made a quit attempt. So again, we're working on analyzing those right now. And then for Fit Connect, we improve pain, mood, and activity. And again, those are things that matter and conversations we're having every day. It doesn't have to be to a formal YMCA program, but just getting patients walking can make a huge difference. And your recommendation matters. That'll resonate with patients. So we have tools, kits, and videos available at the Hip Exchange website. Heidi mentioned that I'm at the Health Innovation Program. She has tools here as well, I believe. If people are interested in any of that, you can see a 2-minute demo of how this works in the clinic space. And this is just a really brief quote that I liked. And it was just saying, that the rocket science in health and healthcare is really delivery. How do you make it easy to do the right thing? And I think that's kind of true. I want to acknowledge and thank all my collaborators, including the health services, or the health systems engineer that works with me, and all the folks that are on our research team, including Emmanuel, our statistician, Emmanuel Sampane, and all of the other collaborators, Heather Johnson in cardiovascular medicine, Pat McBride, a number of folks who have helped us with this work, including Mike Fiore over the Tobacco Cessation Center. With that, I will take any questions that you all have. Go ahead. Yes. Yeah.
How do I get your program implemented? I mean, when I was in Chicago, I realized my focus as a gynecologist wasn't just on cervical cancer. That really is not on the top 10 of death for women. My focus became on cardiovascular health. And so how do we get these? These are things that we don't necessarily want to have to deal in, but it's where we can get these patients rapidly referred for blood pressure check if it's high, the diabetes, the A1C, because I think we need to globally as gynecologists look at patients. If the A1C is high, we need to get them into their primary care doctor. You know, because you have a healthy patient at 73 that thinks she's really healthy, comes in and sees you for a gyne visit, but her blood pressure is 173 over 90. And you're like, you have smoking time bomb.
Right.
And or a smoker or the exercise, patients have issues with exercise. So I would be very grateful if you could help me somehow, at least in the resident clinic that I see, implement these changes.
That's terrific. So it's timely that we're writing a grant to look at doing this in other clinics. So that would be one thing that we can talk to you about, is maybe a formal collaboration if you'd be interested in that. And the other beautiful thing is, is it a UW Health clinic or is it a UW Health clinic? The cool thing is these tools exist in the EMR, so we can talk a little bit more. You can send me an email afterwards, actually, if you wanted to, and we can talk about that over the next few months. We'll be talking about that in next few months to years, talking about getting these implemented more widely. Go ahead.
Thanks so much for coming. Great work. I just was curious if you worked with Meritor at all or Unity Point, and if you have any success stories there.
It's a great question. So to date, we have not collaborated with Meritor and Unity Point, but we'd be definitely open to that, to think about that in the future here as well. So our focus right now is thinking about building out a greater trial. And if they'd be, if you have ideas of who might be interested, I'd love to talk with folks there. Go ahead.
Thank you for a wonderful presentation.
Thank you.
You're advocating to put the patient back in patient care. I guess you can call your presentation empathy in medicine.
Thank you. You're very kind. Thank you.
Christie, that was great. You mentioned the MIPS benchmark for follow-up is 28 days, and your intervention got it from 71 to 38, which is amazing. But how are you, or have you identified the reasons that we're still not able to hit the benchmark? Because it's probably very important for the enterprise to get to those MIPS benchmarks.
So the cool thing is that we, the baseline level, and I'm glad you asked that, and that you're interested there. So the interesting thing is that our baseline rates for hitting that benchmark were that 28% of our patients were hitting the benchmark, and we were able to get that up to about 50% of our patients hitting that benchmark. And the national average, as it turns out, is 29%. So we actually would have been probably the top 99th percentile, and we totally would have gotten the MIPS bonus based on this progress. So better is better. It's not perfect. And again, we're working on ways, we're talking with patients now and trying to figure out, again, what are their barriers to accepting that referral, right? Because that's the other piece here, is that I give you the referral, and then what are your barriers and how can I reduce those to get even higher than my 50% at that 28-day mark? But we're working on it. You're right. It wasn't a perfect fix, but part of that's because it's then in the patient's hands as well. Great question. Yeah, so primary care availability, and that's a great point too. And one of the things we did here was we actually, I'm glad you brought that up too. Great points here. One of the things that we did was we actually talked with primary care, and it turns out they have skin in the game because they're getting quality reported on this. And even if the patient has a high blood pressure in ophthalmology, the primary care doc gets dinged for that last contact. So they've been saying, send them back. So formally us sending them back, they're willing to see these patients, and they were willing to say that they could get nurse visits without a copay in a lot of instances too. If it's what the smart set is actually smart enough that if your pressure is between 140 and 160, it'll say you can get a nurse visit. If it's greater than 160, it says you need an MD visit because we figure you probably need medication therapy. But the cool thing is primary care has been open to this here and also at Gundersen because they totally have skin in the game. And we're getting around that with sort of using nurse visits and things like that too. But I'd be open to other ideas folks have. Go ahead.
In addition to our specialties, our usually primary care folks within our own clinic, and many of our patients utilize those primary care physicians.
Yes.
And just recently, we had a discussion within our department that we're going to contact our internist to see how we can better improve it. But the issue of getting in with the MD versus the nurse visit and the comfort level of the primary care physician, I mean, certainly in many instances individualized based on the patient, but I was wondering if there's within the UW health system protocolization as far as criteria that like the general internists have accepted for nurse visits, or is it really individualized? The doc has to decide what their comfort level is.
So for blood pressure visits, that 140 to 60 was agreed upon by all of family medicine and all of internal medicine on the primary care leadership board. So the cool thing is that 140 to 160 could be an MD or a nurse, but greater than 160 will always be an MD. They've agreed to that. And that in between range, if you had someone you felt really strongly about, I mean, I think you could probably flag that, put a note on that follow-up order. But the cool thing is this is going to blow out to your scheduler. So when they check out with you from your clinic, they're going to get scheduled follow-up with you, but they're also, the scheduler is going to schedule them in primary care and call over and actually make that appointment for the patient if they agree. Other questions?
Okay, everybody, let's give
Thank you.
Dr. Bartels a huge round of applause.